Maybe I'll just start sharing my should I start sharing my slides just to make sure everything works and that sort
Yep,
of thing?
you can go ahead and do that, and I will start off. So welcome everyone to our Friday CFAR conference. Thank you for joining, and happy sort of middle of summer to everybody. So upcoming conferences, we have cases next week, so please do join us for that. But I don't want to take too much time away from the topic for today, which we are extremely fortunate to have in our midst. Dr. Anna Durbin, you might want to switch screens.
Oh, okay. Let's try that.
Just do this, the swap displays at the top.
Okay, let me see that. Very good.
So Dr. Anna Durbin, who is Hopkins faculty, that looks perfect. Who and an expert in immunization of exotic diseases like dengue and measles, who's having a resurgence and a loss of exoticism with the current outbreaks of many of these vaccine preventable illnesses. So I will waste no further time and turn it over to Dr. Durbin, who's going to give us a measles update and some ACIP news.
Great. Thank you, Eileen. It's great to be here. I always love the Friday conference. I'm going to just say that I have consulted with Merck and Company, and Merck is one of the vaccine manufacturers for the measles vaccine. Dengue and measles have one thing in common, and that's rash. So that's always fun. I love to look at these viral diseases that cause rash. I'm going to cover the clinical presentation, vaccine recommendations, management of measles, the current outbreak, and then just give you a brief update on the status of ACIP. So measles virus is a paramyxovirus. It's a negative sense, single-stranded RNA virus. And actually, when I was at the NIH in my post-ID fellowship training, I used recombinant DNA technology to make a PIV3 virus that expressed the HA of measles, thinking we could have an intranasal vaccine. So got to know a little bit about measles then, and was able to also test my measles titer to make sure that I did in fact have antibodies against measles. And I think, as you'll see in the news, in the recent news, or at least in some of the news, particularly from the HHS secretary, who may describe measles as it's nothing, it's just a mild disease, it's nothing to worry about. It actually is a very serious disease that has serious complications, and was described in the 10th century as a disease more dreaded than smallpox. And if you'll recall, at the time, smallpox had close to a 30% mortality. Measles is one, if not the most infectious of our infectious diseases. It is highly transmissible. It has an R naught of 12 to 16. And for those of you who aren't epidemiologists, that means that one primary case can result in 12 to 16 secondary cases of measles in unvaccinated or non-immune people. 90% of susceptible household contacts will develop illness. And that's why we see the numbers that we're seeing this year in terms of the measles outbreak. We need about 95% vaccination coverage for herd immunity to work, because this disease is so transmissible. So a little bit about the vaccine and the virus itself. So Enders and Peebles isolated the virus in human and monkey kidney tissue culture in 1954, and that led to the ability to make a live attenuated vaccine as well as a killed vaccine. So the first live attenuated vaccine was the Edmundston B strain of vaccine, and this was licensed for use in the US in 1963. There was also a second sort of a little bit additionally attenuated strain that was the Edmundston Enders vaccine strain, and that actually came into use more when the Edmonton B strain was withdrawn due to higher numbers of side effects. And so this was replaced with the Edmundston Enders strain. There was also a killed vaccine that was licensed. This was withdrawn in 1967 because it was not as efficacious. And actually, it's one of the two viruses, or vaccines, I should say, it's one of the two killed vaccines that we know is associated with antibody-dependent enhancement of disease. And there's an atypical measles syndrome that is related to the killed vaccine, in that people who were immunized with the killed vaccine and then were later exposed to measles developed an atypical measles type syndrome. And I actually saw a case of that in my ID fellowship in the 80s. But that vaccine was withdrawn in 1967. In 1971, we went to the combined vaccine MMR, which is measles, mumps, and rubella. And then in 2005, with the chickenpox vaccine, we have a combination vaccine, MMRV. Measles in the US was declared eradicated in 2000. And what eradication means is that there's no ongoing measles transmission for more than 12 months. And I will say, I think all of the experts today fear that we are going to lose our measles eradication status with the current ongoing outbreak. So before vaccine was available, measles virus infection was nearly universal, and we still see thousands of cases of measles in under-vaccinated places and places where the vaccine just is not available. It is so infectious that more than 90% of people had immunity by age 15 because they had been exposed to the virus and been infected by age 15. And I believe 50% of the population was known to be infected by 6 years of age. So it's very, without vaccination, without immunity, it's highly prevalent and highly infectious. It's still estimated that there are about 3 to 4 million cases of measles annually, which is really tragic when we know we have a safe and effective vaccine. When the vaccine was licensed and uptake began in 1963, the incidence of measles decreased by more than 95%. And it was one of the greatest public health impacts in terms of vaccines that we have today. The initial recommendation was to administer a single dose of the vaccine at 12 to 15 months of age. And the reason it was delayed to 12 to 15 months of age, again, this is a live attenuated vaccine. And if it's given earlier, then maternal antibodies run the risk of inactivating the effect of the vaccine, because those antibodies can neutralize the vaccine and render it inactive. These recommendations changed to include a second dose at 4 to 6 years of age, and it changed in 1989 because there were several outbreaks that included children 5 to 19 years of age. So 68% of the measles cases at that time was found to be in children 5 to 19 years of age. So a second dose was recommended for age 4 to 6 years old. I do want to say that this second dose is not a booster dose. This second dose is a catch-up dose. So we know that anywhere between 5 and 10% of people may not respond to the first dose of vaccine. That's why we give a second dose as a catch-up, not as a booster dose. We know that one dose of measles vaccine generally elicits about 93% protection against measles, whereas 2 doses increases that to about 97%. Oop, wrong way. So now we're going to go into the clinical overview, and this is, I think, very important so that we can identify cases of measles and really think about measles when we see someone particularly presenting with a rash. So this is an acute viral respiratory illness, and it's characterized by high fever as a prodrome up to 105, and then the 3 C's, which stand for cough, coryza, conjunctivitis, with coryza being, of course, the runny nose. People also feel very tired. They just feel crappy. And then you may have the pathognomonic anathema Koplik spots, but I will say that they're hard to spot. They're not always common. They do precede the rash, which is helpful in terms of making a diagnosis of measles. If you see Koplik spots in the setting of someone with fever, 1 or more of the 3 C's, you can be pretty sure that this is measles. The rash is a very characteristic rash. Again, I'll show you photos. It usually appears about 14 days after exposure, and it starts at the hairline or the scalp and then descends from there. So this is the case definition of measles, and you need to have a fever of greater than or equal to 101 degrees Fahrenheit, a macular papular rash that lasts 3 or more days, and at least one of the 3 C's, cough, coryza, or conjunctivitis. If you suspect measles, you don't have to confirm measles, but if you suspect measles, it's critical that you report that to the health department immediately so that they can do investigations and be on the alert for more measles cases and ensure vaccination and other preventive measures. So this is a Koplik spot. I'm not sure how well this is really projecting, but what you're seeing is sort of a reddish background here on the palette. And then you can see tiny little white spots that look like actually a little bit of reflection. You can see it better on this slide here. This is a Koplik spot back here. And again, this reddish erythematous background on the buccal mucosa here. But you're really looking for little white spots on this reddish background. But as I said, they can be very difficult to see. And the rash, I think, is important to note that the rash can look different depending on your underlying skin color. It can be very difficult to see in persons who are very dark-skinned. And so you want to look not only just for the color, not just for the erythema, but also note that it's macular papular. And you can really see that more clearly up here. So you may not see that erythematous background on this child's skin, but you can appreciate on the forehead there the macular papular consistency of the rash. This is a very typical rash here. As I said, it really starts at the hairline and behind the ears, and then it spreads downward to the neck, trunk, and extremities. We're used to seeing this very patchy erythematous macular papular characteristic of the rash. Again, on this child that has a little bit darker skin, it's a little bit harder to appreciate the change in color, the macular erythematous nature of the rash, but you can see this here under the eyes and on the cheek as well. So it's really important to look carefully for the rash and note the rash when present. I think it's also important to note, and it's interesting, guidelines recommend that isolation begin 4 days before the rash through 4 days after the rash starts, because that's when a person is infectious. But of course, you can't predict when the rash is going to start. So it's really important if you suspect measles, even before the rash presents itself, to begin isolation. So why is measles such a serious disease? Well, there's a lot of complications that are associated. There's acute complications associated with measles, and then there's later or delayed complications. The acute complications of measles include diarrhea, otitis media, pneumonia, and encephalitis. And the pneumonia and the encephalitis can be quite severe. And encephalitis in particular can lead to death, and it's estimated that the case fatality rate for measles can be as high as 1 to 2 per 1,000 cases. The other complication that we don't talk too much about, but that's noted in many, many studies of measles, is that measles is actually immunosuppressive. So once somebody has measles, they are physiologically immunosuppressed for weeks to months afterward and can be more susceptible to other diseases. The complications that we see most commonly in children who are very young, younger than 5, and adults, particularly the pneumonia in adults, can be quite severe. 30% of measles cases in the US were reported to have one or more complications, and that can lead to high hospitalization rates. And it is estimated that about 1 in 5 cases of measles results in hospitalization. You'll see at the end of my talk, when I go through the current outbreak, that currently we have about 13% of the cases being hospitalized, but that can be, again, that's quite a large number of cases when you're in the midst of an outbreak. The most severe complication of measles is subacute sclerosing panencephalitis, or SSPE. And this can occur, this is delayed. It occurs at an average of 7 years after measles infection, but it can occur later than that and is uniformly fatal. It is a devastating complication of measles infection, and we can't really determine who may develop that and who may not. So this is from the CDC, and I like this slide because it gives you a really good appreciation of the timeline of the illness. And it's important to note here, and they have this in red here on the bottom, that patients are considered to be contagious from 4 days before the rash starts to 4 days after the rash appears. And that's in this red area here. And patients should be isolated during that period to try to prevent spread of illness. You can see that the incubation period can be from 1 to 3 weeks post-exposure. And then the rash generally starts about 14 days post-exposure. So there's a lot of time here when someone could be infectious and we might not necessarily pick up on their illness. And because of how infectious the virus is, other people can be exposed and infected again, which is why we're seeing the spread, why this virus spreads so quickly and so efficiently in non-immune populations. So for treatment of measles, there is not a specific antiviral treatment. In some cases of severe disease, people have tried ribavirin, but it's not, it's not a proven treatment for measles. There's not any real specific antiviral treatment. I know in the news, you've probably heard this, there's controversy about vitamin A treatment and measles. Vitamin A treatment was really recommended in low middle income countries and kids who were malnourished and were vitamin A deficient. We knew that they did worse with measles than people who were not vitamin A deficient. And that's why WHO may recommend vitamin A supplementation in populations where we suspect, or children who we suspect are malnourished and don't have adequate vitamin A levels. Vitamin A may be administered to infants and children under the supervision of a healthcare provider as part of supportive care, but you really have to be careful that you don't give too much vitamin A. And we've seen this even in this outbreak where children actually develop vitamin A toxicity because of, recommendation to use vitamin A to prevent measles or to treat measles. And it is not preventative. It does not prevent measles. It is recommended for children who are hospitalized with measles. And excuse me. And again, this has to do mostly ensuring that their vitamin A levels are intact and to help with their clinical course. Again, vitamin A does not prevent measles and is not a substitute for vaccination. As I've said earlier, patients should be isolated while they are contagious, and that's 4 days from before the rash onset through 4 days after rash onset. And airborne precautions should be initiated in healthcare settings. It is, again, spread by droplets and highly contagious. So I'm going to move on now to vaccine recommendations for children, for adults, for people living with HIV. So children, again, we mentioned this a little bit earlier, receive their first dose at 12 to 15 months of age, and then they get a second dose at 4 to 5 years of age. Again, we delay vaccination until 12 months of age because of maternal antibody and how that may interfere with the take of the vaccine. However, if you have an infant who is 6 months of age or older and has not, and is traveling to a place where we know that measles is circulating, if they're traveling to an area with an outbreak, they can receive a vaccination at 6 months, as early as 6 months of age, to help protect them during that setting. If they do receive a vaccine at 6 months of age, then they should receive 2 additional doses per the recommended vaccine schedule. Adults without evidence of immunity should get a dose of MMR, and I'll talk about what evidence of immunity is in just a minute. 2 doses are required for high-risk adults, and so high-risk adults are healthcare professionals because they may come in contact with people with measles, international travelers who are traveling to areas where we know that measles is circulating, post-secondary school students because they may not, excuse me, we want to get them up to date and make sure that they have a vaccine take, which is why they're recommended 2 doses. Again, you don't have to wait years to give that second dose. You just have to wait 28 days or more. So you can give a single dose to a healthcare professional, bring them back in a month and give them that second dose, as well as international travelers and post-secondary school students. So you just have to make sure that you give that second dose 28 days or longer apart. Make sure that interval is at least 28 days. So who is immune and who isn't? And this comes up a lot. I know I get questions all the time from patients and from other healthcare professionals. How do I know that somebody's immune? And this is current CDC guidance that has been in place for many years. If you have written documentation, if somebody has a vaccine card, and we in the US are bad about that. We don't give our patients vaccine cards. Now that we have medical records, it's much, much easier. But I know I don't have a record of my vaccines from when I was a child. But if you have written documentation of receipt of the MMR vaccine, 1 or 2 doses, birth before 1957 because measles was endemic then and everybody was exposed by the time they were an adult. Laboratory evidence of immunity, which is really just an IgG test, so you can send a blood sample out to your local lab and get a titer. Any titer is positive, that's fine. And then prior laboratory confirmed diagnosis of measles. And if you do suspect measles, it's recommended that we get oral pharyngeal swab or nasal swab testing by PCR as the primary diagnostic measure for confirming measles. Also send a blood sample along with that for antibody testing. Now, persons who were born before 1967 may not know if they got an inactivated measles vaccine or the live attenuated vaccine. And so if they received the inactivated vaccine, they should be revaccinated with a dose of the live vaccine. Again, the inactivated vaccine was not effective. So what about international travelers? So again, all US residents older than 6 months of age who will travel internationally should receive the MMR vaccine prior to departure if they are without evidence of immunity. If the infant is 6 to 11 months of age, they get a single dose of MMR, and then that is followed then by 2 or more doses on a typical pediatric schedule. Children who are older than 12 months of age, they get 2 months of MMR, 2 doses of MMR separated by at least 28 days. So you're sort of condensing their vaccination schedule into the 28 days so that they're protected when they are traveling internationally. And then teenagers or adults, if they don't have evidence of immunity, and again, they're traveling to areas where measles is circulating or in an outbreak setting, they should also get 2 doses of MMR separated by at least 28 days. And again, that's to ensure that you have a vaccine take, because we know that about 5 to 10% of people don't get a vaccine take with that first dose. And so the second dose is really a catch-up dose. So post-exposure prophylaxis, and I think this is really important for our immunocompromised patients who cannot receive a live attenuated vaccine. You can do post or pre-exposure prophylaxis if you know that somebody is traveling to an outbreak, an area of an outbreak, or an area where measles is circulating. You can give immunoglobulin to immunocompromised people who cannot be vaccinated. For people who can be vaccinated and they've been exposed, you can give the MMR vaccine within 72 hours of initial measles exposure, and you can give immunoglobulin within 6 days of exposure, because that has a longer effect. It takes the vaccine a while to get replicating and inducing an immune response. So it's recommended to be given within 72 hours of exposure. Immunoglobulin can be administered within 6 days of exposure. And again, immunoglobulin can also be used if you have an immunocompromised person who maybe for whatever reason has to travel to an outbreak setting. That can also be given. It's really, really important, though, to note that you cannot give the MMR vaccine simultaneously with immunoglobulin, because the immunoglobulin abrogates the effect of the vaccine, and it binds to the vaccine and essentially inactivates it. It renders the vaccine inactive. So you cannot give immunoglobulin simultaneously with the MMR vaccine. What are some contraindications to the measles vaccine? Any severe allergic reaction after a previous dose of vaccine is a contraindication, as it is with all vaccines, or any severe allergic reaction to any component of the vaccine. Known severe immunodeficiency, and I've listed them there, and this becomes more common as we have all of our immune modulating drugs that are being used are, as with all live vaccines, contraindications to vaccination, because the concern is that that vaccine will replicate unchecked by the immune system and could cause more complications. Persons living with HIV who have a CD4 count less than 15% or less than 200 are considered to be immunosuppressed and shouldn't receive the measles vaccine. And then, of course, pregnancy as well, because it is a live vaccine. We also have some precautions to measles, mumps, rubella vaccine, or MMRV. Now, a precaution is really is a condition in a recipient that might increase the chance of severity of a serious adverse reaction, or that might compromise the ability of the vaccine to produce immunity. So that's why we have precautions. A moderate or severe acute illness with or without fever is a precaution, because if that person gets worse, if they develop more severe symptoms, we won't know, is that the vaccine that's causing that, or is that the illness that's causing that? Recent, and this is in parenthetically within 11 months, recent receipt of antibody-containing blood products. Now, the specific interval depends on the product, because again, what we're concerned about are, does that blood product contain antibodies that might inactivate the vaccine? So depending on what that blood product is, you may have a shorter duration than 11 months. History of thrombocytopenia or thrombocytopenic purpura is a precaution, because there have been cases of thrombocytopenia following the measles vaccine. Patients recovered, the platelet count recovered, but again, with that, it's a precaution because of the concern that it could happen again. And then a need for TB skin testing or interferon gamma release assay testing is also a precaution, again, because there is concern that although the measles vaccine has not been demonstrated to be immunosuppressive following vaccination, there is, because we know that measles there is some concern that it may change the outcome of that testing. So the recommendation is that you wait a bit for that. And then personal or family history of seizures is because measles vaccine can cause a fever post-vaccination. And again, we've seen with different vaccines, high fever and febrile seizure post-vaccination. That's why this is a precaution. These are not contraindications. These are merely precautions. So now I want to move on to the current measles outbreak. And this is a really fantastic tool that Bill Moss told me about a few weeks ago. If you'll remember, during COVID, Hopkins had a COVID tracker where they could track the number of cases of COVID globally and in the United States. And Lauren Gardner, Sean Truelove, and Bill Moss got together from their specific schools and put this together for the U.S. measles tracker. And, you know, one of the concerns, I'm just going to put it out there, one of the concerns I think that we all have is that we're, you know, do we have the same confidence in the data coming out of CDC, particularly around measles? So what this tracker does is it actually gets data input from all of the individual health departments throughout the United States. So they're not relying on CDC data, they're relying on the data that gets sent to the CDC from the source. And this is up to date. It's really easy to use tool. This is the website here where you can access it. And I think they've done just a really fantastic job with this to keep us all updated. So this is here, the current measles outbreak through July 9th, and which is epidemiological week 27. In the past 2 weeks, there were 62 cases. What you can see here in blue are locally acquired cases, and in red, imported cases. And something I learned when I was preparing for this talk that I think is interesting is that the vast majority of the imported cases that we have of measles are actually unvaccinated U.S. citizens traveling abroad, acquiring measles abroad, and bringing it back into the United States. It's imported, yes, but it's imported by US citizens. And then what you can see is the size of the circle is the size of the outbreak. So you can see, as we all know, that really the outbreak is centered here around Texas, New Mexico, Oklahoma. But we do see cases again throughout the United States. And it's important, really important, to have a high index of suspicion for measles in case we see people coming into the ER. So I'm sure you also all heard in the news that this is the largest outbreak in 33 years. It is certainly larger than any outbreak since measles eradication, and is continuing to grow. So the largest outbreak before this outbreak was in 2019, and that again was centered really around an unvaccinated religious community in New York. We are currently up to more than 1,000 cases, 1,293 cases, and we're just, a little more than halfway through the year. It may, if you look here, may have started to plateau a little bit, but I think, the concern is, again, that the way measles spread is we could continue to see cases throughout the end of the year and may, in fact, lose our measles eradication status. So this is where most of the cases are, and you can see that Texas, New Mexico, Kansas, but Texas really is the leading state in this. And as you know, this again is centered around a religious community that was not vaccinated, that lives very rurally. It's not, they weren't necessarily opposed to vaccination, but they're very rural, don't access healthcare frequently, and so had a large number of unvaccinated individuals. And then this is the percentage of reported measles cases by vaccination status. And I did think this was interesting. I sent an email to Bill when I saw something in the news that HHS reported this as 6% of cases occurred in vaccinated, as opposed to reporting it as 94% of cases were in unvaccinated people. So it's all about our messaging, right? But I think what this really shows you is the vaccine is highly, highly efficacious. And this is 1 or 2 doses. It's not, this isn't broken down by number of doses. But what we know is if we want to prevent measles, vaccination is the way to prevent measles. And then if we look at a breakdown by years, what you can see is really evenly spread almost through 0 to 4 years, 5 to 17, and 18 plus years. I will say that the deaths were more frequent in children. There was 1 death in an adult. It's not exactly clear if he died of measles or died with measles, and I don't think we'll know because he died at home, and there's not a lot of more information that we're going to be able to get. But certainly it shows you that any age group, if you're not vaccinated, you can get measles. And some of the complications in adults, as I said, particularly pneumonia, can be quite severe. So just a summary of the outbreak is, the measles outbreak is ongoing. It's the highest number of cases since 1992 and continues to grow. 13% of patients with measles in this outbreak have been hospitalized, and we have 3 confirmed deaths. The US, I believe, is really highly in danger of losing its measles-free status. And these outbreaks are really driven by drops in vaccination rates. And we're seeing, I'm focused on the outbreak that we have here in the United States, but we're really seeing increasing numbers of measles cases globally, with increasing vaccine hesitancy and dropping of vaccination rates. The coverage in these states, particularly Texas and New Mexico, has dropped well below the 95% threshold needed for herd immunity. And that's why we're seeing a lot of cases in this area. How we, the big message is, I guess, or the big thought is, will this drive people to get vaccinated? Will this help people appreciate the value and the importance of vaccination? I think it's too early to tell, but we know that the greatest, most effective way to prevent measles is by vaccination. So I'm going to move now on to ACIP because I think this ties very well into vaccination and where we are. So ACIP is the Advisory Committee on Immunization Practices, and it's been in place for 60 years. It recommends if and how vaccine should be used, whereas FDA approves vaccine for use. So the FDA will tell you that a vaccine is safe and that it met its primary endpoint. So we'll say efficacy. So the FDA will say, yes, we approve this vaccine for use because it has been demonstrated to be safe and efficacious. ACIP will then say, okay, this vaccine is approved for use. How are we going to use it, and make recommendations on who should be vaccinated, how it should be incorporated into the vaccine schedule, that sort of thing. ACIP recommendations are the cornerstone of the immunization program in the US. ACIP is what we call the Technical Advisory Committee to vaccine usage. So every country, just about in the world, has a technical advisory committee that instructs that advises the country on how to use different vaccines. And the ACIP is the technical advisory committee for the US. Just getting ACIP approval has consequences. It means something beyond just this vaccine is available for use. ACIP approval guarantees insurance coverage for some, if not all, vaccines, and it guarantees eligibility for the Vaccine Injury Compensation Program. And that's critical. So if somebody feels that they've been injured by a vaccine and that vaccine was approved by ACIP, they can then apply to the Vaccine Injury Compensation Program and be compensated for that injury. If a vaccine is used outside of ACIP guidance or outside of ACIP recommendations, it is not clear that it would be covered by insurance. It is not clear that the Vaccine Injury Compensation Program would cover any injury from that vaccine. As we all know, June 9th, Secretary of HHS fired all 17 members of this committee without cause. And I will tell you that ACIP has a very, very rigorous process for appointing and approving members to this committee. It generally is about a 2-year process to finish the vetting process by ACIP. What happens is that CDC puts out a call and says, we're looking for X number of members, because they rotate off of a term, generally a 4-year term, but you can be reappointed. And so they'll put out a call, 1 to 2 years before people are to rotate off and say, we're looking for X number of members. People can apply. They're required to provide letters of recommendation for that. As part of their application, they have to fill out in-depth conflict of interest declarations, as do all government employees, but particularly for ACIP. And then there's a rigorous process to go through those applications and to determine if a member should be on the ACIP. Many ACIP members have divested themselves of interest in different pharmaceutical companies or vaccines, knowing that if they want to be on ACIP, that they should do this. This did not happen for any of the ACIP members that were appointed, as you can imagine, because they were appointed within days of the 17 members being fired. I should also say that the background of people on ACIP has generally been those who are specializing in pediatrics, in immunology, in vaccine sciences, obstetrics, internal medicine, infectious diseases, public health. They understand epidemiology. They understand how vaccines are used. They come from medical practice. So they're practitioners who are utilizing these vaccines, who are talking with patients. This is not the case in the people who replace the 17 members. Most of those on the committee have ties to vaccine hesitancy groups, or oppose vaccines, or have sued vaccine manufacturers, or have even worked with Kennedy's anti-vaccine group. My opinion, I'll just say out here, my opinion is that these are all conflicts, although not financial conflicts of interest, certainly conflicts in terms of how they approach vaccines. And it's very worrisome. It's very worrisome, I think, to people who work in vaccines, but also to, general practitioners, to people who are seeing patients, who are recommending, who are taking care of patients. And it's concerning to patients in terms of will they be able to have access to vaccines. So ACIP's recent verbal recommendation, this hasn't come down in writing, against the use of COVID vaccines for healthy persons younger than 65 and pregnant women is concerning because it goes against the previous ACIP recommendation. And it also does not seem to really assess the benefit risk profile of these vaccines in these populations. We know that pregnant women are at high risk for serious complications from COVID. Now, when these recommendations were verbalized, there was really no scientific rationale for that. What they said was, and this was almost the same statement that came out of FDA and was an opinion piece in the New England Journal of Medicine saying, well, we really don't, we're going to look at this more rigorously, and we don't think that there was transparency around how these were approved. And, right now, so we're not recommending that they be used for these populations. I think, this is really unfortunate. And I know that a lot of obstetricians and pregnant women, and I think are very concerned about inability or difficulty in terms of accessing pregnant women. It also doesn't make a whole lot of sense because pregnant women are considered in an immunocompromised state and should qualify for vaccines because people with comorbid conditions younger than 65 are still, it's still recommended that they get COVID vaccine. So this, as you can imagine, I'm sure you've read about in the press, caused a lot of controversy and consternation. And, I was very pleased to see that professional agencies are stepping up and saying, this is not right. We don't feel confident that vaccines are going to be evaluated using scientific rigor and evidence-based medicine to come up with our recommendations. So there's several groups that will be sort of making their own recommendations. And includes the this includes the American Academy of Pediatrics, the American College of Physicians, the American College of Obstetrics and Gynecology. IDSA has also joined a lawsuit against the government for the firing of the ACIP members. AAP, ACP, and ACOG have said that they are going to work to develop recommendations outside of ACIP. Maybe these, it'll be interesting to see how often recommendations are aligned, how often they aren't. I think one of the complications of this is how do you know which recommendation to follow? How do you get the word out? How do regular practitioners know which recommendation to follow? And I think all of this is sort of in flux. We really don't know what's going to happen. There is a project called the Vaccine Integrity Project that was launched in April by the University of Minnesota's CIDRAP, and it was really launched in response to Senator Kennedy becoming HHS secretary. So their mission is to ensure vaccine use in the U.S. remains grounded in the best available evidence and focused on protecting the public. Again, they're considering developing their own recommendations as well. And I think it's really important to see these groups step up. I think whether or not how complicated things are going to be in terms of which recommendations to follow. And again, coming back to, will insurance cover vaccines if they are not recommended by ACIP, but they are recommended by some of these other groups? I think we still need to wait and see. I was on a call today with the Institute for Vaccine Safety here at Hopkins, and even just trying to figure out if there are competing recommendations, how are clinicians going to decide which ones to follow? And I think there's a lot that still needs to be worked out. I will say that everybody is very, very concerned about this. And I think rightfully so. You know, I also saw that Kennedy just recently also canceled the Public Health Task Force meeting, which also, you know, makes recommendations on several different things. So I think, unfortunately, I don't have a lot of concrete answers for you right now. I will say there's a lot of that's in flux, but you know, I think what I'm very excited about is that there are groups that are stepping up. And I think what we really have to continue to do is make our voices heard, stand up for our patients, and, you know, fight for scientific integrity in terms of decision making and care. And so, you know, I will say there's more to come. Hopefully we'll have more updates in the upcoming weeks and months, but there's still a lot of question marks. And I'll leave it at there and take questions if anybody has any questions.